Hey, Mike Gibson coming to you live from SCAI 2018 here in San Diego, and I'm joined by Jim Hermiller and John Forrest. We're talking about the intermediate TAVR patient. Tell us a little bit about where we're at, Jim.
Yeah, so we have two trials, both with the Edwards valve and the self-expanding core valve, that if we look at those studies compared to surgery, TAVR looks better for many reasons, and certainly the survival risk of stroke is either lower or no higher, and so it's a really great value proposition for TAVR in those patients.
Yeah. John, tell us, we've done a great job with the high-risk patient. Now we have these intermediate-risk patients. Obviously, we're scaling up to do all this. I mean, how does that change the landscape? How are we going to accommodate all of these patients?
I think, it's a great question. I think, first and foremost, at established centers, if it hasn't already, it really does need to become a clinic where you're seeing all aortic stenosis. No longer are we just seeing the patients who've been turned down for surgery or coming there and are saying, I'm expecting to have a transcatheter valve. I think we know that a lot of situations where certainly transcatheter valve is going to be beneficial, but even in these intermediate risk patients, there can be anatomic considerations where you say, you may actually be better off with a surgical aortic valve in this setting, and I think it's important that we recognize that, and truly that that our structural centers, our TAVR clinics, whatever, isn't really a TAVR clinic. It's an aortic valve, an aortic stenosis kind of clinic, if that's what you're saying.
Who is the perfect intermediate risk patient for TAVR now?
Yeah, I think a patient who meets the clinical intermediate risk, whether that be comorbidities, issues about frailty, whatever, it makes them an intermediate risk candidate, either an SCS of over 4%, or they've got other comorbidities or frailties that maybe aren't included in SCS that the team thinks they're more than a 4% risk for surgical AVR. And they don't have any anatomic issues that are going to put them at risk when they have a TAVR. Low coronaries. They've got issues with their aorta. They've got multivalvular disease that you're not going to treat with just a TAVR. They've got very complex coronary disease that, putting 12 stents in an intermediate risk patient who should really just get a SAVR and bypass surgery would be the better option.
Right. Well, guys, thanks for joining us today. Thanks for coming to SCAI, and thanks to all of you for joining us here from SCAI 2018.